Speaker for today's session is Dr. Bushra Shamim. She is an associate professor of radiology at Liaquat National Hospital, section head of MRI, supervisor and examiner of FCPS, and director of residency program. I have got some opportunity to learn from her back in the days when I was at Liaquat National Hospital. Please welcome her on stage.
Bismillahirrahmanirrahim. Okay, today we'll discuss the role of MRI in rectal carcinoma. As Dr. Asghar said, in pre-chemotherapy treatment, in staging, MR has a very important role. In fact, it's a vital role. In this presentation, we will go through the relevant anatomy, which is important for diagnosing the rectal cancer, then MR technique, its pre-operative and post-operative, pre-treatment and post-treatment imaging. Diagnosing rectal cancer is very important, and before diagnosis, we must know the normal anatomy of the rectum. The rectal wall actually comprises of 3 layers. These are mucosa, submucosa, and muscularis propria. Among them, mucosa and muscularis propria are low in signal intensity or black on MRI. The intervening submucosa is bright or high signal intensity. Surrounding this wall is a layer of fat which is called mesorectal fat, and this fat contains normal structures which are blood vessels, lymph nodes, nerves. The amount of the fat depends on the body content of the patient, and later on it is surrounded by a thin layer of hypointense signal which is called mesorectal fascia or MRF. As Dr. Asghar said, we must have to see whether tumor is MRF positive or negative. So knowledge of MRF is very important. Beyond MRF, any signal abnormality is called T4 disease. So the content of mesorectal fat, amount of mesorectal fat is very important. Normally, the content of fat reduces in the lower rectal segment. Then what are the boundaries of rectum? From where to where down? The rectum ends at anorectal junction, and the demarcation of anorectal junction on imaging is the visualization of thick muscles of the anorectal junction. In this coronal image, we can see the red arrows are actually indicator of the thin boundary of the upper and the lower end of thick muscular layer of the anal sphincter. This is the boundary of anorectal junction on coronal image. And on sagittal image, the anorectal boundary is a pubococcygeal line. It is taken from lower end of the symphysis pubis to the coccyx, and this line actually falls at the anorectal junction, which is marked by red arrows. Then comes the upper limit. Upper limit is actually the rectosigmoid junction, which is also known as sigmoid takeoff on imaging. On sagittal, it is the point when the sigmoid colon sweeps horizontally anterior to the rectum. It is not very easy to identify in routine practice because of the bowel loops, presence of multiple bowel loops in the pelvis, but this is the landmark. On axial images, it is the point when the sigmoid colon projects anteriorly in front of the rectum. Again, when bowel loops are distended, there are too many bowel loops in the pelvis, it is not easy to identify. Then comes the second objective, which is MR technique. Performing MR is important in CA rectum that high field Tesla magnet is selected. 1.5 to 3 Tesla is sufficient for rectal cancer staging. Below this field strength, like on 1 Tesla or below 1 Tesla, we cannot differentiate the different walls of the rectum, and so staging is not appropriate. All high field Tesla magnets are provided with multi-channel coils, and these coils provide good imaging quality. Optional things are endorectal coil, bowel preparation, use of antispasmodic agent, or a rectal gel, but they are not necessary. I personally don't use them any, apart from few cases when I had to use rectal gel for detection of small cancers. In planning, we do a large field of view imaging of whole rectum, including axial, sagittal, and coronal. But the most important thing is the thin axial slices, which are of 3 millimeter, and they are taken in axial plane, which is exactly perpendicular to the tumor section. And why it is important, let me show you. This is axial section, and the horizontal lines are actually the plane of the axial section, which is actually perpendicular to the vertical axis of the body. The axial image obtained here shows that the tumor is in relation or in fact inseparable from the uterus. What I was talking about is the axial plane, which is perpendicular to the rectal cancer. What is the orientation of the rectum cancer? We decide that and take the axial section perpendicular that orientation. And when image is obtained in this plane, we can clearly see that there is a very fine line of fat between the tumor and the uterine cervix. So this plane, and believe me, in routine practice, we sometimes have to take 3 or 4 such blocks because long segment of rectum is involved, and rectum is a curved structure. Then our third objective is staging, which is the main purpose of staying here. Tumor itself appears as intermediate signal. It is not black, it is not white. It is intermediate or gray signal apart from mucinous tumor, which are very high. They are rare, they are very bright on T2 weighted images, and they are always have bad prognosis. So let's discuss the T staging. T staging is actually the involvement of different layers of the rectum. We'll see them one by one, and that's why it was important to identify the rectal layers on MRI. T1 and T2 tumor. T1 is confined to mucosa and T2 is confined to submucosa. So collectively, T1 to T2 tumors are confined to the rectal walls, and the best indicator is that the muscularis propria, the outer rim of muscularis propria, is intact. In this polypoidal tumor, we can appreciate the muscularis propria is well intact here. Another example, the tumor is from almost 3 to 9 o'clock position, but outer layer of muscularis propria is intact. It means it is T1, T2 tumor. Then comes T3 tumor, is the tumor that crosses the muscularis propria. It is again categorized in A, B, C according to the depth of invasion. These are the few examples. T3 AB, which is beyond the muscularis propria from 1 to 5 millimeter. If it goes 5 to 15 millimeter beyond the muscularis, it is T3C tumor. And if it involves the mesorectal fascia or MRF, it is called T3 tumor, T3D tumor or MRF positive tumor. So this is very important to decide how and chemotherapy is given for how long time, and in post-treatment staging, we must have to see is it MRF negative now or not. Then comes T4 tumor. T4 tumor are those which involve the peritoneum. They are called A if they are only peritoneal involvement, and B if extra mesorectal organs are involved, and that organ can be any structure, can be blood vessel, fat, or even bone. So differentiation of mesorectum and peritoneum is very important on imaging, and there are different landmarks that in lower rectum, mesorectal fat and fascia encircle the rectum completely. In mid-segment, anterior peritoneal reflection lies anteriorly, and mesorectal fat and fascia is just on sides and back, while in upper rectum, the peritoneum lies anteriorly and on sides, and fascia lies only posteriorly. So these things help us in staging the upper, mid, and lower rectal cancer staging. So how to identify this peritoneum on imaging? This is really very difficult to identify on imaging. And what we have to do, we must have to look for the axial section that lies just below the visibility of first bowel loop appearance or the sigmoid takeoff. Reflection appear as a V-shaped structure on axial image, and on horizontal image it appears as a horizontal line at the level of seminal vesicle or at the uterine fundus. So these red arrows actually indicate the peritoneal reflection, a subtle V-shaped structure on axial image and a horizontal line on sagittal image. Most of the time it is easy to identify on sagittal image rather than axial. These are the few examples of T4 tumor. Apparently, it seems like T3 MRF positive tumor, but anteriorly we can see that there is involvement of seminal vesicle indicating it is T4 tumor. A large tumor involving uterine cervix. Another tumor that was of lower rectal cancer but had involved the sphincters. Once lower rectal tumor involves sphincters, it is T4 tumor. And this example, although none of the organ is involved, but the yellow outline is actually the boundary of the mesorectal fascia, MRF. And the tumor has simply extending into the obturator fat. If it has crossed the mesorectal fat, it is T4 tumor. Another independent in prognostic indicator is extramural vascular invasion or EMVI. When it is present, it is a bad prognostic indicator, indicates local recurrence, poor survival, and poor prognosis, poor response to treatment. And how we can appreciate it? It appears as a tumor signal intensity within the vessel, which appears expanded. These are the few examples. The intermediate signal tumor is visualized, and not only in the rectal wall, it is extending into the surrounding vessel as a tubular structure. In the next example, the tumor itself was apparently as T3A or B tumor, but a long circular vessel which has similar signals to tumor is present here, and it is a very bad prognosis to the treatment. Then comes N staging. In N staging, we have to decide involvement of the nodes are either regional or non-regional. Regional nodes are those which are excised during the surgery, and they include superior rectal, mesorectal, internal, and obturator nodes, while non-regional are distant nodes, and in case of rectal cancer, internal and external iliac group and inguinal groups are called the non-regional. But one exception is here: in cases of lower rectal tumor, inguinal lymph nodes can be considered as regional lymph nodes. What is the criteria of their involvement? We categorize in N1 and N2 disease. If 1 to 3 lymph nodes are positive, this is N1 disease. If more than 4 are present, it is N2 disease. And what are the suspicious nodes? If they are rounded, enlarged, heterogeneous, or have irregular margins. So these are the examples. In first example, the node has 3 densities. It has intermediate signal, low signal, and high signal. This is a heterogeneous signal in the terms of MRI. It is a malignant node. In second example, the mesorectal and obturator, both lymph nodes groups are present. Both are enlarged and heterogeneous in signal. Then our next objective was post-chemoradiotherapy imaging, post-CRT imaging. For post-CRT imaging, it should be performed 6 to 8 weeks after the termination of the CRT and immediately before the surgery. And more important thing is that the pre and post images should be compared in the same protocol and in same planes. This is very important. Practically in my institute, what I found difficulty that first imaging is performed from other institute, second is performed from other institute, one is on low Tesla, one is on high Tesla. So we cannot compare apple with oranges. This is something, practically this is something very difficult. Then what we have to do in restaging tumors, we have to consider the proportion of the remaining tumor, that was intermediate signal, and the appearance of the fibrosis, that is low signal on MRI. So the tumor restaging after CRT is actually a different grading system which is called tumor regression grade, TRG, tumor regression grade. That is different grading system. It has 5-tier grading system. I will show you in next slide. And we evaluate the proportion of the tumor and the fibrosis. This is the 5-tier grading system, tumor grading system, in which grade 1 and grade 2 are the complete or good response, in which there is total fibrosis, intermediate signal of tumor is not there. And in fact, at this stage, diffusion weighted imaging plays a vital role. If no restricted diffusion is there, it is good response. Then good treatment response is one when there is major proportion is of fibrosis and little bit of tumor intermediate signal is there, and on diffusion weighted images we can see some specks of restriction. while in 4 and 5 grades are those in which the major component is the tumor intermediate signal, little fibrosis, and significant restricted diffusion. This is not as easy as shown on the this slide, but tumor regression grading is totally different imaging method and total different mind frame imaging. This was a T3A tumor in which there was subtle extension into the mesorectal fat, and after CRT, the content of the fibrosis was there, but almost equal amount of intermediate tumor was also there. So this was a poor response, TRG stage 4. Then another example in which a bulky tumor was there, and after CRT, extensive fibrosis was there, intermediate signal was almost negligible. So this is a good response to the tumor, TRG grade 3. This is all for today, because otherwise TRG is a totally different story in which we have to consider each and every dot of the tumor, each and every dot of the lymph node, and the EMVI, each and every aspect that was reported in the pre-treatment imaging must have to be reported again in the post-treatment reporting to compare whether response is good or not. Thank you.